Welcome to the i3 Health podcast, where we explore the latest advances in medical research and treatment. I'm Katie Cook from i3 Health. Dedifferentiated liposarcoma is an aggressive subtype of soft tissue sarcoma. Diagnosis remains challenging due to its complex karyotypes, quantitative genomic profiles, and pleomorphic pathological features. Numerous novel therapies are under investigation, with the potential to transform treatment. Due to the complex management of DDLPS, collaboration among the multidisciplinary healthcare team is critical. This i3 Health podcast episode will explore strategies to optimize the diagnosis, treatment, and management of DDLPS. It features perspectives from the Dedifferentiated Liposarcoma Task Force co-chairs, Dr. Richard F. Riedel, Associate Professor in the Division of Medical Oncology at Duke University Medical Center, and Dr. Candace L. Haddox, Physician at Dana-Farber Cancer Institute and Instructor in Medicine at Harvard Medical School. This activity is supported by an independent medical educational grant from Boehringer Ingelheim Pharmaceuticals, Inc. Free CME credit is available for this podcast. To claim credit and obtain further information, including faculty disclosures, visit i3health.com/DDLPS. Additionally, you can view the Dedifferentiated Liposarcoma Position Statement, now published in Cancer Treatment Reviews.
Well, thank you everyone for joining this audio podcast. My name is Dr. Rich Riedel from the Duke Cancer Institute in Durham, North Carolina, and certainly my pleasure to welcome you to this audio podcast discussing the diagnosis and management of dedifferentiated liposarcoma. I'm joined today by my co-chair and colleague, Dr. Candace Haddox. Dr. Haddox, would you like to introduce yourself?
Sure. My name is Candace Haddox. I'm a medical oncologist at the Dana-Farber Cancer Institute in Boston, Massachusetts. And I'll also just acknowledge the other task force members that have contributed to our session here. One is Dr. Jason Hornick, who's Chief of Sarcoma Pathology at Brigham and Women's Hospital and Professor of Pathology at Harvard Medical School. Dr. Beth Baldini, who's Director of Radiation Oncology in the Sarcoma Program at Dana-Farber and Brigham and Women's Hospital. Dr. Vicky Keaty, who's a medical oncologist and clinical director of the Sarcoma Center at Vanderbilt University. And finally, Dr. Chrissy Rowland, who is Chief of Sarcoma Surgery and Associate Medical Director of the Sarcoma Center at MD Anderson Cancer Center.
So Dr. Haddox and I, along with the colleagues that you just mentioned, had the pleasure of participating in a multidisciplinary task force earlier this year. And as part of that task force, we really focused on the management of an extremely rare type of sarcoma called a dedifferentiated liposarcoma. And out of that task force actually came a recently published position statement published in Cancer Treatment Reviews, where we not only highlighted some aspects from that task force, but also delved a little bit deeper into the diagnosis and management of this particular disease state. For those of you who may not be aware, dedifferentiated liposarcoma is an extremely rare subtype of sarcoma. Sarcomas as a whole have more than 100 different histologic subtypes. Dedifferentiated liposarcoma is one of about 4 or so histologic subtypes that fall under the adipocytic tumor category. Dedifferentiated liposarcomas can be very aggressive. They can often be what we call high grade. There's a propensity for metastases. And what we've learned in managing this disease is that it's really, really critical that patients be seen in centers with expertise and be managed in a multidisciplinary fashion. Maybe Candace, maybe you can comment first and perhaps talk about how we perhaps think about dedifferentiated liposarcomas with respect to particular locations in the body and how might treatment strategies may be changed based on those locations?
Yeah, sure. So 2 of the most common places that we see dedifferentiated liposarcomas are both in the retroperitoneum and in the extremities. And first, starting with the diagnosis and considerations there, liposarcoma should always be considered when a patient presents with a mass arising in the retroperitoneum. Of course, not every retroperitoneal mass is liposarcoma, but it's important to at least consider and exclude this diagnosis or confirm it. Patients can also present with a mass in the extremity that can also be dedifferentiated liposarcoma or another form of sarcoma. So the first step to diagnosis, of course, is biopsy. For patients where there's an adipocytic mass suspected either in the retroperitoneum, the extremity, or elsewhere, we usually recommend targeting the area that's enhancing the soft tissue component. And if there's a PET scan available, really targeting, if it's accessible, the area that's most PET avid, as that's most likely to harbor that dedifferentiated high-grade component. And then once the diagnosis is confirmed, and we can talk a little bit more about nuances of diagnosis, the treatment path kind of splits from there. Surgery is usually part of the management for a localized dedifferentiated liposarcoma, and we'll consider radiation therapy depending on the location, and we'll also consider chemotherapy really depending on the location and whether the tumor has high-grade features.
Oh, as you just alluded to, it sounds like the treatment for dedifferentiated liposarcoma is becoming increasingly complex and nuanced and requires multimodality care, but it really all starts with a diagnosis. So let's delve into that, a little bit. You mentioned the need for a biopsy, and certainly if there are enhancing portions of a tumor mass, targeting the biopsy to those particular areas. After you get a biopsy, what happens?
Then it goes to the surgical pathologist, and of course, we strongly advocate that it's sent to an expert sarcoma pathologist for review. They'll usually start with H&E assessment, but then if liposarcoma is suspected, then additional ancillary tests can be added. So that can include immunohistochemistry for MDM2, which is amplified in liposarcomas, and FISH can also help to identify the amplification as well. On occasion, we'll consider things like next generation sequencing. One thing about dedifferentiated liposarcoma is that it can have heterologous components. So for example, it can have rhabdomyoblastic elements or osseous elements, and that can sometimes mislead the pathologist down a path of rhabdomyosarcoma or osteosarcoma, for example. So in these cases where there's ambiguity, NGS can be helpful. In the right clinical context, it can provide support for a diagnosis of dedifferentiated liposarcoma because that MDM2 CDK4 amplification is nearly ubiquitously present in these tumors. But there's also some downsides too. One key thing to consider is the cost of next generation sequencing. So if FISH or immunohistochemistry and clinical context can all point in the same direction and allow everyone to feel comfortable with that diagnosis, then NGS testing may not be needed.
In our position statement and task force, Dr. Jason Hornick, whose name you mentioned at the beginning, was a valued participant in that. He obviously has expertise in diagnosing this particular disease state. What we learned from him, and as you mentioned, there is a characteristic amplification for MDM2. We also see applications in CDK4. All of these are in close proximity on chromosome 12q. The role of molecular testing as sort of an addition or confirmatory test has become increasingly utilized. Certainly at our institution, we will leverage immunohistochemical stains, but routinely we'll look for FISH amplifications as sort of confirmation of a presumed diagnosis. But to your point, we have to be careful. These tests sometimes don't work the first time around. There needs to certainly be pathologic expertise in the interpretation of these tests. Immunohistochemistry, while relatively inexpensive, is not without potential difficulties as well. It depends on the user and the laboratory technicians that are running the tests. So in the end, we really have to leverage our pathology colleagues who have disease-specific expertise to help aid us in making this diagnosis. So, after a diagnosis is made, we start thinking about management. One of the things that was in our position statement and that we discussed during our task force was, management for patients, particularly with localized disease. You talked a little bit about this earlier, but just briefly, for patients with extremity disease, how do we typically think about localized disease in the extremity?
For dedifferentiated liposarcoma of the extremity, we do tend to think of them like other soft tissue sarcomas. So that includes consideration of preoperative or postoperative radiation therapy. We tend to favor preoperative radiation therapy as we can typically treat those to a lower dose than we would for postoperative radiation therapy. And then the next step, of course, is a good resection with negative margins. So those are the two key elements for localized dedifferentiated liposarcoma in the extremities. And then we will consider chemotherapy as part of the upfront management, although there's a lot of, say, controversy in the field, varying practice patterns. And the root of all of that is because all the studies that have been done have been quite heterogeneous. They're not focused in dedifferentiated liposarcoma. They include several subtypes of sarcomas, different chemotherapy regimens, different drugs, different doses, et cetera. So it's been really hard to tease out really what is the true benefit of perioperative chemotherapy for patients with localized extremity dedifferentiated liposarcoma. One thing that we tend to leverage in our discussions with patients is nomograms, like Sarculator, for example, that can help to risk stratify patients and give us an idea of prognosis. And there are some studies showing that patients that have the poorest prognosis may benefit most from perioperative chemotherapy. So at least it's a starting point to have the discussion. And we'll usually dive into the risks and benefits of chemotherapy before making a final decision about whether ultimately we employ that in the patient's treatment plan.
You mentioned consideration for preoperative or postoperative radiation therapy for extremity disease. Dr. Beth Baldini from your institution was a member of our task force and a co-author on the position statement. She did a wonderful job of highlighting the complexities or the nuance and thoughtfulness that's required when considering radiation therapy, either in the preoperative or postoperative setting, taking into account dose, amount of area, for example, that needed to be considered for radiation therapy. There are obviously both acute and long-term side effects associated with radiation therapy, but clearly for a high-grade, localized, dedifferentiated liposarcoma, I think the key point here is that surgery alone typically is not enough, and multimodality therapy is appropriate. Chemotherapy, obviously, as you mentioned, controversial. There are a lot of efforts and interest in trying to prove beyond a shadow of a doubt that chemotherapy provides a benefit. I think that still is an area of active debate and discussion. How about local management for retroperitoneal dedifferentiated liposarcoma? How has the treatment paradigm changed or evolved in the setting of recent clinical trial data?
Yes, good question. As you mentioned, it has evolved recently. There was a publication of the EORTC STRASS randomized trial, which evaluated preoperative radiation therapy versus no radiation therapy. And that actually showed similar outcomes between both of the arms. So typically radiation therapy for a localized retroperitoneal dedifferentiated liposarcoma is not offered. Chemotherapy, we're actually evaluating that right now. There's the global randomized STRASS-2 study, which is going to investigate neoadjuvant chemotherapy for patients with high-grade retroperitoneal sarcomas, including dedifferentiated liposarcoma. So probably still looking at a few years to accrue and have data mature before we have an indication about whether neoadjuvant chemotherapy adds benefit here. So we're eagerly awaiting those results too.
We talk about the evolving treatment landscape and obviously mentioned radiation therapy. It's also important to note that surgical strategies and techniques have evolved over time. And Dr. Chrissy Rowland, again, a member of the task force and position statement from MD Anderson, really provided a nice discussion regarding surgical considerations, particularly for retroperitoneal sarcoma. Our European colleagues will do surgeries that can oftentimes result in multivisceral involvement. Less so here in the United States, but the point is that I think the sarcoma community as a whole is coming together to try to refine operative techniques and ultimately try to improve outcomes, all in an attempt to provide curative intent therapy for patients with localized disease. Certainly for localized disease, we talked about multimodality therapy, certainly with radiation therapy and surgery for extremity disease, largely surgery alone for retroperitoneal disease, with the role of chemotherapy in both settings being active areas of exploration. Let's just transition a little bit and talk about the role of systemic therapy for the metastatic disease setting and how we have evolved, both in terms of the number of options and the effectiveness of those options for our patients.
We discussed in the task force some of the most common frontline regimens that we will consider, and I think there was some consensus among us that anthracycline is a common frontline chemotherapy that's offered to patients with metastatic dedifferentiated liposarcoma. Other regimens that have been either investigated or used commonly as standard care therapies include gemcitabine-based therapy. But then we also discussed that eribulin and trabectedin are two chemotherapies that have been tested in randomized trials for dedifferentiated liposarcoma compared to dacarbazine. So both are also options. And we discussed that eribulin, while it didn't show much improvement in median progression-free survival relative to dacarbazine, actually showed an improvement in overall survival. So that tended to be something that was favored amongst us on the task force. And then aside from the traditional chemotherapies, there are a number of treatments that are under active investigation that are more targeted therapies. One example of that is the CDK4/6 inhibitors. Palbociclib has been studied previously in liposarcomas, both well-differentiated and dedifferentiated. While one would think with the CDK4 amplification of these diseases that this is an attractive target, palbociclib really showed modest outcomes in these trials, mediocre PFS and low objective response rate. But the more potent CDK4/6 inhibitor, abemaciclib, is in trials right now, and we're awaiting those data. But early result discussions suggest that there's some promising activity there. So it'll be exciting to see the final data from the ongoing phase 3 study.
You mentioned trabectedin, you mentioned eribulin, anthracycline, gemcitabine-based regimens, and now some sort of emerging therapies with CDK4/6 inhibitors. I think one of the reasons why we've seen some of these advancements an increasing number of options in a rare histologic subtype of sarcomas, because we've gotten smarter about our clinical trials in the past. I've been around long enough, sadly, that I can say that in the past we used to perform clinical trials where we would enroll all comers. And what would happen is we would oftentimes be left with a negative phase 3 clinical trial, and we were trying to pick up the pieces to try to understand if there were hints of activity. The success and subsequent approval of trabectedin and eribulin as examples is largely in part due to the fact that that was a histology-specific trial limited to liposarcomas and another type of sarcoma known as leiomyosarcoma. But I think as we start to get smarter and understand the underlying biology that drives the disease, we're now starting to see the fruits of our labor in terms of seeing successes with these now FDA-approved agents. Certainly, the use of CDK4/6 inhibitors, hopefully in the context of ongoing clinical trials, will show clinical benefit, and they will become regular staples within the treatment realm. One of the other strategies that has been looked at is targeting the MDM2 P53 axis. As was mentioned at the beginning of this podcast, D-differential liposarcomas are characterized by amplifications of MDM2. And so there's an understanding of the regulatory ability of MDM2 and P53 and sort of preventing the ability of MDM2, which is oftentimes overexpressed in this disease state, from inhibiting P53 may actually result in therapeutic gain. And there's been a lot of interest in looking at those sorts of approaches. As an example, there was a recent phase 3 study looking at melatobatan compared to trabectedin in patients with advanced disease, advanced D-differentiated liposarcoma. At least top-line data that we've seen suggested that that study did not meet its primary endpoint, but there continues to be interest in targeting the MDM2 and P53 pathway. There's a series of ongoing studies known as the Bright Line studies, which are looking at brigamadilin. And at least there has been some early phase clinical trial data suggesting efficacy. We obviously are waiting for more robust prospective later phase clinical trial data, but I think there is growing interest as we learn about the underlying opinions of the disease state to sort of leverage that for therapeutic gain. And I think CDK4/6 inhibitors and inhibitors targeting MDM2 and P53 are examples of that. You know, we can't talk about cancer without talking about immunotherapy. Has there been any, what's the update with respect to immunotherapy in D-differentiated liposarcoma?
It's a very interesting topic. And one thing I wanted to touch on was what you said earlier about, sort of targeting the disease biology. And along with that, I think finding good biomarkers to help us predict which patients are more likely to have benefit from specific therapies will be really key. And one space that's really needing that is immune therapy. PD-1 checkpoint inhibitors have been evaluated in D-differentiated liposarcoma. One example is the SARC-028 study, which was a single-arm phase 2 evaluating pembrolizumab, and it had several parallel cohorts, including D-differentiated liposarcoma. That study had an initial pilot cohort of 10 patients with D-differentiated liposarcoma, and then later enrolled an expansions cohort for a total of 39 evaluable patients. And we saw the objective response rate was around 10%, which at face value doesn't sound that exciting, but there was a subset of patients that had durable disease control. Some patients being treated for, several months, even up to a year. Other studies have shown longer durable benefits with PD-1 inhibitors. So, really we're desperately in need of a biomarker to understand who are these 10% that will respond and what is a good biomarker for benefit, even durable disease control. So overall, PD-1 inhibitors in D-differentiated liposarcoma can have benefit, and they're endorsed by NCCN guidelines. And there are some ongoing studies looking at combination strategies. For example, the Alliance study that's looking at cemiplimab in combination with palbociclib compared to palbociclib alone. So it will be exciting to see those data. So I think there's a role for PD-1 inhibitors. Maybe other novel immune therapies will be developed as well. But I think a key as we develop these drugs will be, finding biomarkers that help us select patients. Those traditional biomarkers that we see are helpful in carcinomas, like PD-1 expression and TMB greater than 10, just don't seem to help select the patients that are going to benefit. Although those biomarkers can be enriched in the patients that benefit, we still see that patients that have little to no PD-1 expression or low TMB that respond. So I think this will be a critical area of sarcoma research going forward.
I think if nothing else, it just tells us that there's still a lot of work to be done in this particular disease state. But I would say, the future is really bright, not only in D-differentiated liposarcoma, but in sarcoma as a whole. We have a number of clinical trials that are becoming increasingly specific to individual subtypes. dedifferentiated liposarcoma is a clear example of that. And in our position statement, there are a series of tables that actually highlight ongoing clinical trials, as well as previous trials that have actually led to paradigm shifting, treatment changes for patients. And so certainly what I would say is for those listening that clinical trials really should be considered for all patients with advanced disease. That's how we move our field forward. And certainly for any individual who is dealing with a diagnosis of dedifferentiated liposarcoma, really consider partnering with your local academic center with disease-specific expertise. So we can partner with individuals in the community and really try to optimize care for our patients. In the closing minute here, I'll just mention that both in our position statement, in the task force webinar, and here in this part of this podcast, I'll just mention that there were some clear consensus recommendations that we had among our group regarding the care of patients. I think just to briefly summarize, first and foremost, review of pathology at a center of expertise is key. Number two, really leveraging a multidisciplinary approach for patients is key in terms of providing the best possible outcomes. Radiation therapy in combination with surgery, I think would be considered standard of care for extremity disease, surgery alone currently for retroperitoneal disease. And then the use of chemotherapy for localized disease is an ongoing discussion. There's a lot of interest, as we mentioned, in doing so. Certainly, for patients with advanced metastatic disease, there is a role for systemic therapy, and it's really great to see that we have a number of options that we are ready to be used in clinical practice currently, but also options that are in active clinical investigation targeting the underlying biology. Any final comments, Candace?
I would just like to reiterate also, as you touched on, that the landscape is evolving. We have a lot of ongoing trials, and eventually that is going to, we hope, lead to improvement in care and management of these patients. So just to reiterate that we're happy to partner with local oncologists and see these patients and help to care for them, and also give them the option and access to clinical trials that are exploring the really fundamental questions in management of dedifferentiated liposarcoma right now. So I think that there's a lot ahead that will be exciting, and at a sarcoma center, we'll be best positioned to, help get patients onto trials and optimize their management.
Well, let me just close the session by thanking everyone for listening to this audio podcast. If there's interest in learning more, please consider checking out the task force webinar, as well as the position statement that was published by the Task Force in Cancer Treatment Reviews, published in November 2024. Thanks, everyone, for joining. Have a great day.
Thank you for listening to the i3 Health podcast. Be sure to subscribe to the podcast so you'll never miss an episode. To claim CME credit for this activity, visit i3health.com/DDLPS. And while you're there, you can check out our other free educational offerings. Don't forget to follow us on social media for free CME, NCPD, and CPE. In addition, Oncology Data Advisor features expert perspectives and news stories on the latest in cancer research and treatment, all found at oncdata.com.